Chapter 10. Chapter 10 is pathophysiology, and basically what we're looking at in this chapter is some selected impairments of homeostasis. So we've already determined what homeostasis is. It's that state of balance and general well-being. And so in this chapter we'll look at how is the person, how's that person's homeostasis affected by a handful of a few medical conditions. As always, simply watching and listening to this lecture is not an acceptable replacement to reading and studying the chapter. You're strongly encouraged to do both. It's a very intense chapter, very in-depth, a lot of detail in this chapter, and it really does play in with the rest of what we're going to learn throughout this class. In general, this is roughly a third the way through the program. So beyond this, we're really going to dive more into assessment and then the actual treatment of the assessment of the various conditions. So, the education standard that goes along with this chapter is the AEMT applies comprehensive knowledge of the pathophysiology of respiration and perfusion to the patient assessment and management. You have a handful or two of objectives for this chapter that are found throughout pages 232 through 234. There's a significant number of those for this chapter. And like I said, it's a very detailed and in-depth chapter. So it's going to take quite a bit of study time in order to appropriately get through this chapter. Coupled with the pharmacology that we're also going to discuss this week, this has the potential to be a mental overload week for you guys. Okay, so as an introduction, homeostasis is that physiologic steady state achieved by the body's complex regulatory mechanisms. So in week 5, we looked at a couple of, actually last week, which I think actually was week 5. Week 5, we looked at and discussed what homeostasis is and some examples of how it gets thrown off. So a lot of those then play into the chapter that we're fixing to go into now. So we're looking at things such as disease, environmental conditions, trauma. These all disrupt that homeostasis, and then that body has to try to respond to correct that, often something that's referred to as compensation. So the body tries to compensate for the issue at hand and then correct it. So our body routinely does this without our awareness. So we don't have to think about when we say cut our hand, we don't have to think about, oh, I've got a clot, I've got a clot, I've got a clot. It's just a natural reaction that the body notes, hey, there's a loss here. Hormonally, something happens, it triggers something else, and then another hormone is dispatched. And that in turn creates some sort of a response by the body. Disruption of homeostasis can be very severe. We take somebody, say, who has a sudden cardiac arrest or a sudden cardiac death, in which that person went from basically functioning very well, being very healthy, and able to handle most of the little curveballs that get thrown at it, to being completely unable to breathe, unable to pump blood. Therefore, within a very short time after that, the other systems begin to fail. So we can have something really severe. The body's compensatory mechanisms can respond but are not sufficient. So the body does have some things that happen when the respiratory drive stops. Remember, we only take a fraction of the oxygen out of the blood each time it goes around. So in a way, there's a compensatory mechanism right there that we can go for a few minutes without oxygen simply for the fact that we have some stored. The body's going to kick in some of its own hormones and stuff to try to stimulate everything else. The body knows, hey, I need to shunt blood to the core. Signs and symptoms can appear, but these can be very superficial indications, and sometimes we don't even get good indications. Sometimes things are happening and we have no idea that they're even happening. And then things can get complicated when we have multiple problems going on. So and it's going to be our goal then to recognize some of these signs and symptoms and look at what causes them, where do these things come from. So we need to define the following terms: physiology, pathology, and pathophysiology. So all of these can be found in your text on page 234. We have physiology, that's the study of the function of the body. We know that from the AEMT chapter. Anatomy is structure, physiology is function. Pathology is the study of disease, and the effects and the progression of that disease is then called pathophysiology. So they all link together, obviously. All diseases and injuries have effect on the body at a cellular level. It may not be huge, it may not be significant, but each disease and injury will affect the body at a cellular level, whether it's the amount of oxygen that's available or the amount of sugar that's available or the pH changes, or maybe it's the amount of water available. All of these things will take some effect on your cells. And then the body is fairly predictable in the way that it responds to specific threats in homeostasis. So when we kind of look at these, we look for these patterns, and when we see these patterns, then we can usually say, oh, I wonder if this is not going on the inside. Because in EMS, we really are at a disadvantage when it comes to diagnostics. The reason that we're so disadvantaged is the fact that we don't have a lot of tools. We don't have a lot of tools in the field that we can use that the docs get in the hospital. So the docs can order radiographs, such as they can order x-rays and CT scans and MRIs, nuclear studies, and so on and so forth. They can order a battery of lab tests, blood, urine, saliva. They can do cultures and whatnot, and those results help them pin this stuff down. We don't have that advantage in the field, at least yet. The day will come in which paramedics will be doing a lot more diagnostic in the field with the help of technology, where there's going to be more diagnostics at hand for advanced providers, simply for the fact that as we continue to have a growing shortage of healthcare providers, physicians, whatnot, and particularly in the rural areas, we're going to have to look more at who else can do some of these diagnostics. And with the way that healthcare is evolving, we're seeing more and more treat and release. We're going to be taking fewer patients to the emergency room. And if we have advanced practice paramedics out there that can do a diagnostic and say, hey, you really don't need to go to the ER. Let's set you up with an appointment to go see your doctor. That's going to benefit the whole system. All right, think about it goes with your case study in your textbook. Okay, so a few mechanisms of homeostasis that can be disrupted or can be a disruption themselves. Hypoxia. Obviously, that's a lack of oxygen. Nutritional imbalance. And most of the time when we think nutritional imbalance, we might be thinking something like sugar, but it can be the vitamins and the nutrients and the proteins and so on and so forth that go with it. Genetic diseases. Sometimes we have genetic issues in which the body can't process something, or it overprocesses, or it's just missing something altogether. Cancer. Cancer is actually a mutation and an adaptation that occurs in some people. Actually, it occurs in all people. Everybody has cancer. It's just most of the time kept in check. Physical injury, so trauma, of course, that can wipe out circulating blood flow, that can destroy certain structures that are necessary. Toxins, poisons, overdoses, medications, infections. So when we get an infection where the body has come under fire from another organism, and there's the potential for the organisms to take over. So this table is found in your text on 235, And I think it's really a good table for you guys to spend a little bit of time on. It talks about some examples of how hypoxia may occur and then the pathophysiology that goes along with it. So we'll take, for example, a narcotic overdose depresses the respiratory centers in the central nervous system. So the narcotics, while they help with pain, and that's what narcotics are, they're painkillers, they're analgesics. And when narcotics help with the pain, they're actually not nullifying, but decreasing the central nervous system, depressing the central nervous system. And with that, you get too much, you depress the respiratory center in that central nervous system. So it's going to cause that decreased respiratory function will make the respiratory slow, makes them very shallow. That inadequate amount of air reaches the alveoli for gas exchange, so it decreases our functional tidal volume that we have, as opposed to that the dead space doesn't change. It's just what gets down there to the alveoli that changes. So this results in poor oxygenation. The blood returning to the lung is therefore inadequately oxygenated, and it cannot deliver high levels of oxygen to the cells. Obviously, without that oxygen, the cells switch to anaerobic metabolism, and they produce much less ATP. Without ATP, those cellular mechanisms fail and cell death occurs. So you may not think about it in such depth, but that's the sort of thing that now at the advanced level we have to do. We've got to think about how is this affecting us all the way down as far as we can go in the system. And luckily for us at the AEMT and the paramedic level, we could administer a drug called naloxone or Narcan. And Narcan works only on narcotic overdoses. It doesn't work on any other class of drug. It has to be an opioid. So morphine, toluene, Dilaudid, heroin, codeine. So all of those opioids can be reversed by Narcan, and that's a drug that we can carry. So we're going to touch on that when we get to the medications chapter. Nutritional imbalance. For example, patient takes his insulin, does not eat. So this increases this amount of insulin in the body, facilitates the entry of all the available glucose into the cells, but there's no additional glucose source around for the body to use. So very quickly, the glucose goes into the cell, it gets used, it gets converted, it turns into to energy, and then all of a sudden you run out of gas. There's no more fuel in the tank, and so the body just quits, and it goes unresponsive until it starts to try to scavenge a little bit of sugar from other parts of the body, but that remaining glucose is not enough to fuel the entire metabolic need of the cell. ATP is not produced, and those cellular mechanisms then again start to fail, and within a relatively short period of time can start to die. So again, we have a drug as AEMTs that we can give that will help reverse this. We actually have a couple of them. Glucose, oral glucose. The best way for the body to get sugar into it is to eat. However, if we have a patient that's completely unconscious, that may not be possible. So then we may have to go to dextrose, 50%, 25%, which is basically concentrated sugar in water. Or one of our other backups is a drug called glucagon, and glucagon then goes to the liver and robs some of the stored sugar and puts it into a usable form. Physical trauma. So a patient falls from a second-story roof. When he lands, a screwdriver in his tool belt impales him on his right side, lacerating his liver, and his liver begins to bleed profusely. Liver is a solid organ. Solid organs are very, very blood-rich, and he's going to bleed. It's very easy to bleed to death from simply a liver laceration. So with the decreased number of red blood cells, there's inadequate oxygenation and glucose being delivered to the cells to fuel that metabolism. The mechanisms begin to fail, and unless that bleeding is stopped quickly and the red blood cells are restored, the patient will die. Well, we cannot do anything about replacing blood in the body, However, we can do several things to help with bleeding control and shock management. We may be able to give them some IV fluids that helps. It will dilute the red blood cells, but yet there will be now enough volume in the system to transport what little red blood cells are left around. Eventually, if we don't do anything about the bleeding, but we just keep pumping fluids into them, we wash all the red blood cells away and all that's left is salt water. Infection. So the patient with pneumonia. The cellular debris in the fluid will fill up the alveoli in the affected lobe. It prevents oxygen from diffusing across that respiratory membrane and into the blood, and less oxygen reaches the cellular level, and that impairs metabolism. Not to mention the toxins that are still floating around through the body, which can get to other places and cause other infections. We can also have that cellular debris start to clog up the kidneys, and it can become a big mess real quick. Toxins, so say faulty, or backing up to infection. With that infection, we don't often have the answer to the infection, but we have some supportive measures. So in this case, perhaps using CPAP on this patient. Higher levels of O2, ventilating them as necessary. Some IV fluids to help them become rehydrated, because patients with pneumonia are often dehydrated. So stacking the deck with that oxygen can help us get around this one. Toxins. So the faulty gas furnace releases carbon monoxide into a resonance. Carbon monoxide binds with the hemoglobin. In fact, it binds the hemoglobin 200 times faster than oxygen does. And it prevents oxygen from binding to it. Oxygen is not delivered at the cellular level, and this impairs the cellular metabolism, causing eventual cell dysfunction and death. That's pretty simple. This is a very easy, or not very easy, very low-tech fix here is simple high oxygen ventilation. Eventually they may need to go in for hyperbaric therapies, but at this point there's not a bunch of cool drugs and whatnot that we need to do for this person. We simply need to get them reoxygenated. The environment. The person locks his keys in his car. He's unable to get back into his car or into his house. It's about 2 degrees Fahrenheit out, 20 mile per hour wind, and his closest neighbor is 3 miles away. So his body's going to lose the heat to the cold air. This effect is going to increase substantially by the wind. We add that wind chill, makes it that much more dangerous. Despite the shivering and the exercise from walking he's going to get, the body's going to be unable to generate enough heat to maintain the core temp. The electrical system of the heart is going to become irritable. The nervous system begins to malfunction, and less oxygen released to the cells and the tissues. So with that, we have a very, very irritable body, and the body's lost a lot of its energy, and eventually the body starts to go into a shutdown mode, something called the mammalian diving reflex. So obviously warming them up, again, another low-tech issue here. We don't have a lot of cool drugs and whatnot we're going to give this person. If we have warmed IV fluid, that's great. That might be helpful. Some ambulances have IV fluid warmers, and that will help improve the body's temperature, core temperature. But things like warm packs, removing the cold, wet clothing, and just trying to keep the heat up in the ambulance helps immensely. Then we may have some other cool technological toys we can use along here, but it's just general warming. Okay, so mechanisms of disease and injury. So we look at a couple of categories of mechanisms here and how they may affect our body. And things such as a hypoxic cellular injury, shock, impaired glucose metabolism, electrolyte and pH disturbances, and environmental disorders. So when we look at these a little bit more, some of them are kind of intertwined and mingle. Say a hypoxic cellular injury, that could be something as easy as a crushing injury, or if somebody's arm was pinched in something. They would be losing oxygenation beyond that point of the compression. However, shock could just as easily cause some hypoxic cellular injury as well, because when the patient's shunting blood to the core, they're shutting off blood to the extremities. So, impaired glucose metabolism. When the patient is in shock, they may also have some impaired glucose metabolism because their body may be using it up. So they kind of get their fingers in with each other. That electrolyte and pH disturbance, when the body's pH gets way out of whack, that could be from various reasons listed above. But when the body's pH system gets out of that 7.35 to 7.45 range, the body really starts to suffer, and you can become extremely acidic very quickly. That impaired glucose metabolism, we can have diabetic ketoacidosis, which is actually going to ketoacidosis, going to drive the pH down, which makes them more acidic. And then obviously the environmental disorders. We can have a variety of things that play in with that. Say you're shivering, you're going to use up more sugar. Your body's shutting down. It's trying to shunt the blood to the core to be warm. That's a shock-like state. It's a hypoxic cellular injury. So, and like it mentions, considerable overlap. Okay, so you must be able to anticipate the many ways in which homeostasis can be disrupted and be available, or be able, not available, able to intervene with in this pathophysiologic process. So if you treat a patient rescued from a swift water, what disruptions would you consider? So if we had a patient who fell in the water, let's say, well, if you look on page 236, I mean, you have a guy that's being rescued out of a river, looks like there. What would you consider? Well, with water, there's rapid cooling. Even when it's warm out, you can have very rapid cooling. Or if the patient maybe had water in his lungs. So we might have hypoxia from the near drowning incident or the non-fatal drowning incident. We could have hypothermia from being in the water. Depends on how long he's been in the water. Has he had anything to eat? Has his body been shivering? Has he used up all of his sugars? So there's lots of potentials there. Trauma. How did he get into the water to begin with? Did he fall out of a boat? Did he get knocked around on the rocks? How did this all happen? So we have to be thinking more than maybe what we just initially get from the page. We have to be thinking more worldly about the whole situation. So compensation and adaptation. The body is capable of very remarkable adaptations under stress. And will withstand significant challenges in homeostasis. And that's called compensation in the shorter term. Adaptation is a longer term thing in which patients will be changing their body. Their structures will change in order to accommodate whatever it is that has been putting stress on the body. We'll take there's some good examples that we can look at in a chart here in just a moment. That's on 236 in your text. But just some examples of this is anybody who has ever taken up running probably has had to deal with shin splints. Well, shin splints is the body is starting to actually pull away some of that outer lining of the periosteum of the bone. So the body will then build up. The body will strengthen that area and usually will become sort of a ridge along there in the bone where it's actually created a thicker, heavier attachment point. So types of cellular adaptation. If you want to look on these 236, again, another good chart. Some terms you've probably heard before but maybe didn't really understand completely. Atrophy, this is reduction of the size of the cells of a tissue. For example, skeletal muscle atrophy occurs when an extremity has been immobilized in a cast for several weeks. So anybody who's worn a cast on one extremity versus the other, know that once they took that cast off, that there was a significant difference, not only in just the way it looked and probably smelled, but in the way that it was able to function, and the loss of some of the muscles in that area. That's the reason why a lot of times people who are significantly ill require some rehabilitation afterwards. They got to rebuild what they lost from laying in a bed for weeks on end. So these cells adapt to a lack of use by decreasing their size. They don't have to be as large. They don't have to have as much strength. They don't have to have as much ability to move and be used because of the fact that they're fairly immobile. We have a metaplasia. This is a change in the type of cells that comprise a tissue into different types of cells that is not normal for that tissue in order to adapt to changes in the environment. For example, cells that line the esophagus, which are a squamous epithelium, these can change into a different type, a columnar epithelium, to adapt to chronic exposure of stomach acids. So they give you an example of Barrett's esophagus, but even for that matter, GERD, gastroesophageal reflux disease, where you constantly have stomach acids that are leaking back up into the esophagus. So they're going to change their structure, more or less become, we'll say, a type of a scar tissue to accommodate this change in their environment. We have hyperplasia. And hyperplasia, this is an increase in the number of cells of a tissue. So, for example, in benign prostatic hypertrophy in middle-aged men, prostate increases in size and can obstruct the urethra, interfering urine flow. So with this hyperplasia, and maybe this is in response to chemicals or something in the body, hormones. With this hyperplasia, they're building quicker than they're dying off, and so that hyperplasia then starts to constrict the prostate, or the urethra, that is. So, hypertrophy, this is an increase in the size of the cells of a tissue. So the best example of this is the heart, is the growing of muscle following weightlifting. So as you build and build and build, body build, you get hypertrophy of your muscles, and then so the skeletal muscles become large. The number of cells stays about the same, but the size of the cell changes. There's another good example of hypertrophy that occurs that we deal with in medicine on a regular basis. This is called left ventricular hypertrophy. So the left ventricle of the heart gets stronger, thicker, heavier cells in it to deal with the high blood pressure that the heart has to pump against. Remember, we call that afterload. So in response to the afterload, increased afterload, the heart has to become stronger, has to pump harder, and therefore becomes hypertrophied. We have anaplasia. It's a loss of cellular differentiation. This is an indication of malignant tumors. So the cells stop having different structures and different functions. They kind of become more or less zombie cells, more or less. And this is an indication that they potentially have cancer. We may have a dysplasia. In a dysplasia, the cell maturation and differentiation are delayed and results in loss of uniformity of the cells within a certain tissue. So this is often a precursor to cancer, and a lot of times pap smears will show a dysplasia of cells of the cervix, indicating need for further examination and potential treatment to prevent that cancer. So the cells aren't coming and going quite like they're supposed to, and so you have some instability in that tissue. You may have a neoplasia, and a neoplasia is new or expanded growth in an area of the body where it is not expected. So neoplasia can be accompanied by anaplasia. And this, and the degree to which the neoplasm invades the normal tissues, determines whether or not a tumor is benign or malignant. Benign meaning that it is non-harmful, malignant meaning it's harmful or cancerous. Example, a benign neoplasm is a uterine fibroid tumor. So they may have a little fibrous tissue that builds up in the uterus. It ends up being non-cancerous, but you could also have that malignant neoplasm is osteosarcoma, and that's a cancerous bone tumor. So a lot of times those benign neoplasms, they go in, they wipe out the little tumor itself, and that's really pretty much the end of it. They continue to watch, but people who end up having something malignant, then they're the ones that are going to end up with some chemotherapy and potentially radiation therapy, and potentially other treatment options. And then finally, we have apoptosis. And apoptosis is genetic instructions provided by the DNA that can command the cellular self-destruction. So the body's self-destruct button. Either as part of the normal process or to destroy damaged cells that are a threat to the body. All right, so compensation can extend your patient's life under cellular stress. I think we've all heard the term compensated shock. So when we have a compensated shock, our patient is doing well enough to keep going, to extend what's going on, because they've changed the size of their blood vessels. They've caused extra water to go to the vascular space. They've shunted some blood away from the extremities. So that's all compensation. You need to identify these compensations to treat the underlying complaint. So what are some examples of how the body can compensate for stressors? Well, let's take an example of, we may respond to a patient who has a complaint of abdominal pain. They complain of abdominal pain, and that's all we get. And if we simply look at the patient, we notice that they're remarkably pale, maybe even slightly cyanotic. They may be diaphoretic, cool to the touch, and get a little lightheaded when we sit them up. Before even taking any vital signs, we can probably start to guess that this person is becoming a bit shocky. So maybe that abdominal pain is actually a GI bleed, and if we have a GI bleed, that patient real quickly can become shocky, and we don't even see it on the outside. We don't see blood from a GI bleed. Now, if we would then go and ask them the questions, do you have any blood in your emesis? Do you have bloody stools? Or do you see anything that looks black and coffee ground-like? Is it a particularly foul odor, et cetera, et cetera, et cetera? And we take some vital signs and find out that they have a heart rate of 120, and maybe their blood pressure's 100 over 60. Respiratories are about 28. Those are all now starting to wave big red flags at us that, hey, look, this person is under fire and they are in shock. So how does the body compensate for this? Well, the body starts to compensate by, number one, dispatching some epinephrine and norepinephrine. So it has a sympathetic nervous response, dispatches those hormones to start increasing the heart rate, to increase the strength of contraction of the heart. To go along with some of those, we also get some vasoconstriction of the peripheral vessels, so the fingers and the toes and the hands and the feet and the arms and the legs. Those vessels then start to constrict because the body says those aren't necessary to live. I need a liver, I need a heart, I need a brain, got to save those, don't need fingers and toes. So the body starts to constrict blood vessels. Well, a side effect of epinephrine and norepinephrine becoming or being dispatched is diaphoresis. So a sign of vasoconstriction is pale skin. People may also have some nausea and vomiting. If this person didn't have nausea and vomiting with their abdominal pain to begin with, then they maybe developed that as a result of the body's compensatory mechanism of the sympathetic nervous system. So the heart rate went up, the blood pressure goes down, that's not a compensation, but the heart rate going up is trying to compensate for that. Respiratory rate goes up simply for the fact that the body's pumping more blood, still needs that oxygen, pumping harder and working harder, it's going to have a bigger oxygen demand. So a hypoxic cellular injury. In aerobic metabolism, we have glucose that gets into the cell. Remember, glucose requires assistance to get into the cell. If it doesn't get into the cell via the normal routes, it really has a very difficult time getting in there at all. It's very, 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 very inefficient. So the body needs insulin in there to help get that sugar to the cell. So once the sugar is actually into the cell with the insulin, oxygen also makes its way to the cell because we have good perfusion. And usually, the sugar and the oxygen can go hand in hand. If we don't have blood flow, we don't have either. So we get those to the cell, they get inside the cell, they make their way to the mitochondria, and that mitochondria creates ATP, which is adenosine triphosphate. It's about 16 times more efficient to do it aerobically than it is anaerobically. So when we talk about being an aerobic metabolism, the body works so much more efficiently and so much more smooth with the presence of both oxygen and sugar. Not being able to get oxygen to the system, the glucose may still get in there, but it creates that very small amount of ATP, and there's a lot of waste product, and that extra waste product that is created is pyruvic acid, and pyruvic acid eventually turns into lactic acid, and as you can tell, either one of those acids take its toll on the body. Changes the pH. Remember, the human body is normally slightly alkaline. 7.35 to 7.45 is just barely on the alkaline side of things. We add more acids to the system, and it shifts that curve. It shifts it over. So without oxygen, then the system just does not function well. So hypoxic cellular injury occurs at any time that our oxygen delivery or utilization is disrupted. Remember that normal PaO2, which is the partial pressure of arterial oxygen, is 85 to 100 millimeters of mercury. It just so happens to coincide with what we consider a livable range of SpO2, so the saturation, O2 sats with the pulse ox. 85 to 100 is what most people consider, well, that's a livable range. Anything below 85 is pretty bad. Same sort of concept, although they are not exclusively the same. So just because you're satting 100% does not mean that you actually have 85 or 100. Well, if you sat 100% does not mean you have 100 millimeters of mercury of PaO2 in your blood. So when the body is functioning without oxygen, it is ischemic, or the cells specifically are ischemic. When those cells are red blood cells, actually, back that up. Ischemia is the body is suffering from a lack of blood flow to the tissues, and it results in hypoxia. We have hypoxemia when that is actually the cells themselves suffering from hypoxia. So a few different terms that get thrown around. So body can compensate only within certain limits. Body has a few minor reserves, but those reserves can quickly be taxed and can be completely tapped out. Ischemia, again, lack of blood flow to the tissue results in hypoxia and hypoxemia. Hypoxia is the global state of the whole body being ischemic. Hypoxemia is the specific tissues. Cells adapt from switching from aerobic to anaerobic metabolism, and then cells without oxygen become irreversibly injured within about 5 minutes. So if they don't get oxygen to them within 5 to 10 minutes, they're going to be injured within 10 minutes. They're almost guaranteed to be dead. And that hypoxic cellular injury occurs anytime that the oxygenation is disrupted, and that oxygen required to produce energy molecule ATP that fuels cellular work. Without that, all the cell goes into the, basically a scavenge mode. It says, I got to do what I can to keep myself alive. I'm not really going to be able to help with the rest of the body doing whatever it's supposed to be doing. All right, so when working properly, the force of oxygen is pulling electrons through the chain and results in numerous hydrogen ions being extracted into the intermembrane space of the mitochondria. Those ions build up and they change the gradient, and it causes them to synthesize ATP as they exit. Overall, that process is called oxidative phosphorylation. Not terribly important that you remember that, but in case you ever hear it again. And then without ATP, the cells cannot power their reactions and their activities, including that function of the sodium-potassium pump. So the sodium-potassium pump, remember, if we go back, is the process of the body's electrolytes switching places in order to allow the cell to do whatever it's supposed to do. If it's supposed to pass on an electrical message, it's supposed to contract, whatever. It requires that sodium-potassium pump to constantly be resetting the balance. And that process of resetting the balance takes that energy. If we don't have the energy, which is ATP, then the sodium-potassium pump starts to fail. It can't do what it needs to do. So we can take a look here at some hypoxic cellular injury. This shows us an example of the lung alveoli and the capillary network that kind of covers those alveoli, and kind of the interface that we're dealing with here. So we've got the red blood cells within the vessel there. We have the lung alveolus. And basically, as you can see there, it's really two thin membranes, very thin layers that separate red blood cells from alveoli. So it's basically a very thin, almost a tissue paper, if you wanted to think about it, almost a tissue paper-like membrane that separates them. And due to the concentrations of oxygen and CO2, remember, they're going to switch places because they want to be the same on both sides. So when there's typically minimal to almost no CO2 in the atmosphere, the body's going to, the CO2 is going to offload from the body quickly to try to even that out. And the oxygen sees, hey, it's 21% here, 16% there. Let's make that, let's bump that up. Let's make that 21% as well. Okay, so what do we have that we need for adequate oxygen delivery? Okay, we have to adequate onloading of oxygen onto the hemoglobin in the red blood cells. Well, that sounds simple enough, but you have to really think a little bit more in depth about that. How does that happen? How does that occur? Well, you have to have the ability to move oxygen in and out of your body. You have to have membranes that are capable of allowing the oxygen to move across. You have to have the hemoglobin, which is made out of iron, on the red cells. You have to have red cells. You have to have some plasma in the blood to move the red cells around. And that's just to name a couple of quick potential disruptions there. So in just simply saying adequate onloading of oxygen onto the hemoglobin in the red blood cells, that's not the end-all be-all of it. It goes so much further than that. We have to have circulation of the red blood cells through the microvasculature to perfuse the tissues to the body, or of the body. So more so, the plasma comes into play here. We have to have the plasma in order to move these red cells through. We have to have a heart that's strong enough to pump these red cells around. We have to have intact vessels that will allow these vessels to move, or to transport the oxygen through the force of the heart. You have to have these vessels be the right size. They're not broke open, spilling blood. Even if they're super dilated, there's still way too much open area, not enough blood to fill it all. So, and then those we have to go then to the adequate offloading of oxygen to the tissues once the red blood cells reach the microvasculature. So then, if we have edema around those vessels, so the blood can't, or the oxygen can't easily get off in exchange because there's fluid, there's edema in that area. The pressures down in that area, there's very minuscule amounts of pressures, osmotic pressures all over the body, and if the pressures are too high compared to that of the cardiovascular system, they may not be able to easily offload. And then I think there's also a forgotten aspect that gets overlooked, is we also have to be able to onload the waste products. You have to be able to get the waste products out of there as well. The body, yes, we're constantly talking about get the good in, get the good in, get the good in, but we also have to be just as concerned with getting the bad out. I think if most of us tried an experiment, I don't think many of us would last very long, but if we tried the experiment of you can bring in as much goods as you want, bring in all the groceries and physical possessions and whatnot that you want into your house, but you can never, ever, ever take anything out of it, including your garbage. You cannot flush your toilets. You can't get rid of the things you no longer want or need. I think it's very easy to see from that example that we get a toxic environment. We get a very ugly, toxic environment in a very short period of time. So these components can be disrupted in 4 major ways. Oxygen delivery to the bloodstream, oxygen transport within the bloodstream, oxygen transport from the bloodstream to the cells, and then oxygen utilization by the cells. So all these are in way, shapes, and form types of shock. So when we're looking at this, we are seeing that oxygen delivery to the bloodstream is really the respiratory system. Oxygen transport within the bloodstream is the vessels and the blood itself. Oxygen transport from the bloodstream to the cells, this has somewhat to do with the cardiovascular system, but it also has to do with just the cellular environment of how it can move things around. And then oxygen utilization by the cells. We have to have all of the right components in place at the cellular level in order for that to happen. So oxygen delivery to the blood. The atmosphere contains adequate oxygen for us, roughly 21% oxygen, 79% nitrogen, and trace gases, minuscule amounts of other gases, which include CO2, neon, freon, and we can keep going. CO2, methane. I mean, lots of different gases that float around out in our environment. Ventilations must produce an adequate tidal and minute volume to provide oxygenation. So we have to have the physical process of moving the air in and out of the respiratory system. And that physical process has to occur with significant efficiency in order to make it work. If we only had one breath of 350 cc's in a minute's time, that's not going to last very long, particularly because a lot of that 350 cc's is lost in the anatomic dead space. So we have to have a ventilatory rate, a ventilatory status that matches what we need for our perfusion. We've talked about the term a VQ mismatch or a ventilatory perfusion mismatch. When we have a ventilatory perfusion mismatch, then the body is still functioning at its regular rate and level, but the ventilatory status doesn't match that. The oxygenation isn't keeping up with the need. And then the body can compensate for decreased tidal volume by increasing respiratory rate. So if our body needs 6 liters of air in a minute's time in order to do its job, how does it get there? Well, we could have a respiratory rate of 10 and a tidal volume of 600. 10 times 600 is 6,000 or 6 liters. Or we could have a respiratory rate of 15 and a tidal volume of 400. 15 times 4 is still 6. Still comes up to be 6,000. 15 times 400 is 6,000. So it's 6 liters. Either way, we're accomplishing what we need. However, stop and think about that for a moment. It's not going to be as efficient of a process at a rate of 15 as it is at 12, because that rate of 15 was our tidal volume of 400, of which most of that is taken up, or a lot of that is taken up by the anatomic dead space. Whereas with a tidal volume of 600, then much more of that air actually reaches the alveoli and can actually be put to work. So remember that anatomic dead space, things like the trachea, the pharynx, those and the bronchioles, those are areas in which oxygen doesn't get deposited into the bloodstream. That's just structure. That's the street. It can't. It's like think about people's yards. The yards are the alveoli. The streets are the bronchi and the trachea. The alveoli, the yards, that's where the growing, where the actual life is occurring. Whereas the streets are made of concrete. There's really no life there. It's a route. So we have to keep that in mind. Oxygen delivery to the blood. Shallow breathing results in inadequate ventilation. So if we go very shallow, even though we pick up the rate, if we pick up that rate to 32, 36, 40 times per minute, but yet we're breathing 300 mLs of air at the most, so much of that is just totally lost. You can't use it. So you have to keep that in mind. Eventually we get to the point in which we can't compensate. Atmospheric pressure and partial pressures of oxygen decrease at higher altitudes. So we don't have as much oxygen, and it's not as high of a pressure the higher we go. So symptoms of altitude sickness can develop at elevations over 8,000 feet, which here in the roughly the Omaha region, along the Missouri River, we're usually somewhere pretty close to around 1,000 feet above sea level. So we've got quite a ways to go before we have to worry much about being at over that 8,000 feet mark and starting to become ill. But this does happen in the Rocky Mountains. We do see this happen, and that's something that has people that are medics in those areas deal with on a fairly regular basis, people getting sick at those higher altitudes. So when we change the amount of pressure we have in our atmosphere, it changes the amount of oxygen that we actually have available to us. We also could have an airway obstruction. So if we had an airway obstruction, we can't move air in and out. Without an airway, the rest of it doesn't matter. Because if we can't move air in and out, it doesn't matter if the heart's pumping or how fast it's pumping. We cannot transport the oxygen. So there's a lot of things that can cause airway obstruction. It can be a foreign body, certainly. That's when we think of airway obstruction. That's what we commonly think of, is having a piece of steak, a toy car, whatever, lodged in somebody's airway. It may simply just be the relaxation of the tongue and the throat muscles. There's no muscular tone. Anybody that snores has a minor airway obstruction every night. So that relaxation of the tongue and throat muscles. Trauma. maybe we have swelling, maybe we have blood, maybe there's vomitus from the trauma. Allergic reaction, where we get this spasming, we get this extreme closure and edema to the airway that is going to cause it to narrow very quickly. And then obviously swelling from infection, swelling say from croup or epiglottitis narrows that airway up quite a bit, and it makes it much less efficient in the way that it's able to conduct air to and fro. Now maybe we have a nervous control issue. The nerves that control the respiratory patterns and the respiratory function are knocked out. So if we look at this, you can also see this on 241 in your text. If we look at this picture, we have a couple of different pathways that we deal with. Whether we are, there's a stimulating center, there's an inhibition center, and they read the various, what we call baroreceptors and chemoreceptors. Baro meaning pressure, chemo meaning chemical. They'll read these receptors in a few sites, mainly your carotid arteries, and read how much oxygen and how much CO2 do you have in your system, and then that drives your respiratory rate and pattern. Now, they are fed through a set of nerves that then go down to the diaphragm and the intercostal muscles to expand and contract the rib cage. If we would cause damage to either the respiratory center, which we can see we have those various centers, whether the pneumotaxic center and the apneustic centers, as well as the rhythmicity centers. If we disrupt those, it disrupts either the pattern or the rate or both, or we can damage the nerve that leads from them downward. Damaging any of those things certainly can cause us to have a loss of ability to breathe. We also can get the things that screw up those centers, whether we're talking certain types of medications, maybe we're talking a stroke or brain injury, maybe there's actually been a trauma to that area. It's putting undue pressure on there, or the patient becoming hypoxic. All of these things can potentially cause dysfunction, not malfunction. I guess malfunction works too. That would destroy or at least knock out the normal respiratory patterns and drives. So those respiratory centers in the brain, they function to stimulate the inspiratory cycle and then the respiratory cycle, and then anything that restricts the chest wall can decrease pulmonary ventilation. So we put somebody, we crush somebody's chest. If they can't expand their chest, they can't move air in and out. Remember, it relies on the ability to move the chest wall in and out in order to move air in and out. If we don't have that ability, then the vacuum system doesn't work. It's normally supposed to work off of a vacuum. When we have a disease process, asthma, COPD, anaphylaxis, that result in constriction of the bronchioles. Well, if we decrease the size of the streets that we can move the air through, say we go from trying to transport a very large, well, we'll take for example, you're trying to drive a semi. If you're trying to drive a semi down a very skinny little alley in between houses, you could have a very difficult time getting that moved down that alley, simply for the fact that the road isn't appropriately sized for the load that it is needing to carry. So you get bronchoconstriction. That bronchoconstriction, that impairs expiration more than inspiration. So air gets sucked in, it's a little easier to suck it in because it is a active process. The process of exhaling is passive, so it is relaxation that is kind of pushing that air out. It's not nearly with the amount of pressure that inspiration had. And so when we get air trapping, such as in asthma or COPD, that patient may not, their true issue may not be getting air in, it may be getting air out, because if they can't get the air out, there's no room to put new air in. Certain pulmonary diseases can be traced to a VQ mismatch. We just talked about this, ventilatory perfusion mismatch. Can be a decrease in ventilation and lung perfusion, or both. So if an underlying problem is not corrected, they will go into respiratory failure. If they go into respiratory failure and it goes uncorrected, they lead to respiratory arrest or apnea. And if that goes uncorrected, it leads to cardiac arrest and death. So when we say a decrease in ventilation, lung perfusion, or both, ventilation is the process of moving air in and out. Lung perfusion is the ability to move blood around those alveoli to do the gas exchange. A primary example that comes up when we talk about ventilatory perfusion mismatch is a pulmonary embolus or pulmonary emboli. Pulmonary embolus is a blockage or a clot. In most cases, it's a blood clot in a certain area of the lung. Sometimes it's huge and it may take up an entire lobe or more of a lung. Sometimes it's smaller than that. But when we put a blockage in that area, then no blood gets passed. So oxygen is still going in and out, or air is still going in and out of the alveoli there. There's just no blood coming by in order to pick it up and take it away and then take it to the part of the body that needs it. So with that blockage, the patient doesn't immediately suffer. They don't immediately have an issue in most cases, because there are other areas that are not blocked by emboli, but it puts undue pressure, excessive pressure on the other parts of the body, or the other parts of the lungs and the circulatory system, to pick up the pace and to compensate. So when we have a patient with a pulmonary embolus, it is no blood flow to a certain area of alveoli, even though the alveoli function as normally as they normally would. So the alveoli don't realize there's a problem. They're just not getting exchanged. Eventually, this may lead to some leaky blood vessels that will then turn into causing some pulmonary edema in that area. But right off the bat, and in early stages, if you would listen to the lung sound, you know no different from simply listening to the lung sounds, because the air still flows. It's just the blood does not. Oxygen transport in the blood. We may have a couple of things that may cause some issues here, such as anemia. Anemia, this is the number of red blood cells decreased with accompanying decrease in hemoglobin, which reduces their oxygen carrying capacity. Now, this is not always a lower number of red blood cells. Most of the time when we think about anemia, we think, oh, well, they have low red blood cells. Well, that's not always the case. It may just simply be those red blood cells are unable to do their normal job. So if they're unable to do their normal job because they're sickle cell shaped, or they don't have enough iron in the body in order to attach oxygen and move the oxygen around, they are anemic. So we may also be dealing with something as acidosis or alkalosis, which are going to alter the ability of oxygen to bind with and release from the hemoglobin. So when we change the pH a little bit, we change the environment and the accessibility, I guess we'll say, of the oxygen and hemoglobin relationship. In cardiac arrest, the heart stops beating, the oxygen delivery stops too. So if we don't have the blood flowing around, we don't have the oxygen getting to where it needs to go. So we may have things such as sudden cardiac arrest, where there was really very little signs that led up to it. They go into cardiac arrest, that's SCA, sudden cardiac arrest, and they maybe had no pre-existing signs. This happens fairly frequently in the younger crowds that have a cardiac arrest. You may have something such as asphyxiation when somebody suffocates. We've also got listed as one of our terms is CPR, cardiopulmonary resuscitation. Hopefully everybody knows that. And note the way that that last one is spelled, defibrillation. There is no U in there. It's not defibrillation. It's defibrillation. And defibrillation is resetting the heart. It is not restarting it. We don't have a way to restart the heart. We're hoping through defibrillation that we reset it and then it will start up on its own. Sometimes paramedics and docs and nurses will give medications to help try to enhance the ability for it to restart, but we don't have a way to restart it. We just can only hope that we can reset it so everybody will do the same thing at the same time like they're supposed to. So the American Heart Association recognizes this chain of survival. We know that patients in cardiac arrest, for 10 minutes without anything is almost guaranteed to die. 10 to 15 minutes into a cardiac arrest, provided that we're doing something, that patient transitions into a metabolic phase of cardiac arrest, in which the cells have been hypoxic for so long that they're now starting to break down. So remember, when we do CPR on somebody, we're only 1/3 as effective as their heart actually beating. So high quality CPR is paramount. The AHA's chain of survival is we need to immediately recognize cardiac arrest and notify EMS immediately. And then start with immediate CPR with the emphasis on chest compressions. Move the blood around. Remember, there's extra oxygen there. Ultimately, yes, they are going to need oxygen going in and out of the system. But even to get somebody to move the blood around, to distribute the little bits of oxygen that are left, will at least be kind of a stopgap mechanism. Rapid defibrillation when appropriate. Not all patients in cardiac arrest need defibrillation. Some patients in cardiac arrest, their heart is not fibrillating, and fibrillation is just kind of a quivering. We have some heart rhythms that the heart's actually doing nothing, called asystole. We have some that are called PEA, pulseless electrical activity, in which the heart actually, if you would look at it on the monitor, may look like it's doing a normal thing, yet the muscle doesn't choose to cooperate. Early advanced life support, and that's where you guys come in. AEMTs, paramedics, getting that early advanced life support. So taking another step up the ladder there of care. And then integrated post-resuscitation management. Cardiac arrest management does not stop when the patient's pulse returns. There's things that are now becoming more and more commonplace where we have therapeutic hypothermia, where patients are, once we get a pulse back, if we don't get them to bounce back to alert and oriented almost immediately, a lot of places the protocol is to then induce therapeutic hypothermia or get them make their body cold in order to preserve the cells. It's kind of like when you buy a steak. You want to buy a fine steak or maybe chicken or whatever. In order for it to remain fresh and in its optimal condition, you put it in the refrigerator. So you don't want to freeze them. Freezing them does some damage itself, but if you cool them down, it decreases the rate of decomposition. And so by refrigerating our people that are under fire, hopefully we can save some cells. And then slowly we bring them back up out from that as blood flow starts to stabilize a little bit, and they're then able to maintain their own. We may be talking about an alkalotic state. An alkalotic state is a diminished ability of the hemoglobin to deliver oxygen to the tissues that need it. So the acidosis is usually a buildup of, say, carbon dioxide and whatnot. Alkalosis, we maybe are pumping out too many buffers, too many things that are destroying the acid too quickly, and therefore making the environment less receptive. So cyanide is a substance that prevents the cell from using oxygen. An aerobic metabolism cannot occur, so they switch to anaerobic. And usually people with cyanide poisoning die rather quickly. This is a chemical asphyxiant that goes in there and causes the body to not be able to function appropriately. There are some treatments for cyanide overdose. The odd thing, though, is in many cases we don't have time to give it because cyanide works so quickly. So cyanide is often found with carbon monoxide, since it is released from burning more synthetic materials, silks and wools, and is commonly present in smoke from structure fires. And then when cyanide poisoning is suspected, what treatment options are available? There is a kit. Most ERs have the cyanide antidote kit. I don't think I've ever seen one actually used or taken out of the cabinet. In most cases, if we're dealing with a cyanide incident, we probably are not going to have the resources or the time to administer this. Just to see a little bit more on cyanide, you can see that on 246 in your text, where it actually talks about some of those chemicals that get used. An older type of cyanide antidote kit used sodium nitrite, sodium thiosulfate, and amyl nitrate, or nitrite, sorry. More recently, they've started using hydroxycobalamin in the treatment of cyanide poisoning. But the hydroxycobalamin is used to create cyanocobalamin, which is vitamin B12, and that can be excreted through the kidneys. Again, you're talking a very short window here. All right, cells require glucose in order to produce ATP. We obviously know that. You have to have sugar in order to have energy. Sugar is what we use in conjunction with water and oxygen being our three main building blocks of life. And then through glycolysis, which is the breakdown of sugar, ATP is produced through anaerobic and aerobic metabolism. And typically the aerobic metabolism is what we like to run off of. It's the more efficient of the two. So a sudden or significant drop in blood glucose can quickly lead to brain cell damage and death. Insulin must be present to facilitate glucose passage across the cell membrane. So with few exceptions. The nervous system actually is one of those exceptions, in which there just has to be really some sugar present in order for it to be able to get into the system. Doesn't have to have doesn't rely as much on the insulin. Oops. Diabetes mellitus. Understand there are multiple types of diabetes. The one we most commonly talk about, diabetes mellitus, this is the cells being deprived of glucose despite high glucose levels. So the problem with diabetes mellitus is not actually a sugar problem. It is an insulin problem. The insulin either is non-existent or not working efficiently, or they don't have enough in order for it to work how it's supposed to. So glucose does not require insulin to enter the brain cells, like I mentioned. And then when the fatty acids used for energy, because the body's breaking down some of its stored sugars, it creates ketones, and ketones is a byproduct. Ketones smells a lot like acetone, so the ladies that do their nails, or guys that do their nails, I guess, that have used acetone, maybe you've used acetone in the shop, gentlemen or ladies, for other projects, know that there's a very distinctive smell to acetone, and it creates an acid. So insulin lowers that blood glucose level by facilitating cellular uptake of glucose and glucose storage in the form of glycogen in the liver. So insulin basically says, we're going to take some of this sugar, we're going to get it into the cells, and for what the cells don't need, gets left over and just kind of hanging around, I'm going to help it store in the liver in the form of glycogen. So that glycogen gets stored up there, and then occasionally your body taps into it. So those of us that are starving, some days we're really using up some of our stored glycogen. So we can promote that glucose storage through the process of glycogenesis, and then we can also have the body tapping into that and using some of those sugars, which is called glycogenolysis. So when we go in there and we lyse something, we break it down. So we have a drug that we actually use that helps to create glycogenolysis when we use the drug glucagon, which is actually a hormone that normally is found in our body. When we use glucagon, we go and we tap that glycogen stores in the liver, we break it apart, we make it into a usable form of sugar. So the body also has that glycogen, or glucagon, that it can go and in times of need use the extra sugars. So the common cause of hypoglycemia is an excessive amount of insulin in relation to the amount of glucose. So we typically will treat by increasing blood glucose levels, administering simple sugars, either orally or intravenously. So now we commonly think of it as a sugar problem because the people we deal with the most with diabetic problems in EMS are those people that are hypoglycemic. They have low blood sugars. Well, why do they have low blood sugars? It's not because they didn't eat enough, really. It is in a roundabout way, but in fact, the biggest issue is that they had too much insulin on hand at the time. So this is such a common scenario to run into. Somebody gets up in the morning, they go on, put their pot of coffee on, they're like, oh, I'm gonna take my insulin now. I'm going to eat breakfast here in just a second. The phone rings, they run down the hall to answer the phone, or they get distracted. They decide, oh, I should go get dressed first, and then they don't eat, and by the time the insulin really starts to embrace and take effect on their body, it's too late. They haven't gotten their sugar source into their body, and now they're quickly spiraling down into the dirt. So administering simple sugars orally or intravenously, those are common treatments there for hypoglycemia. The thing that I want you to keep in mind here is just because we can doesn't mean we should. Sure, we could stab a person with a needle every time we run into a hypoglycemic patient and either give them glucagon or give them D50 or give them both. You shouldn't need to give them both. You should only give glucagon when you absolutely have to because it's not as efficient as doing either oral or IV glucose. But if the patient's alert, they're kind of talking to us, but they're starting to obviously lose a little bit of their mental status, as long as they have, you're relatively confident that they're able to chew something or drink something and swallow it to get sugar into their body, that's the better method to do this. That's the best way of getting it into the system and getting them to bounce up here quickly and stably. If that is not an option, then we consider IV glucose, whether that's in D5W, D10, D25, D50. And then if we can't get an IV, we can't give them something to eat, then glucagon becomes our third option. So first, if at all possible, oral. So that could be oral glucose as well. So secondly, if that's not an option, IV. And if that's not an option, thirdly, we would go to glucagon. So some signs or symptoms of hypoglycemia. Just very quickly, we're not going to dwell much on this because this is a whole other chapter we're going to get to here in just a couple of weeks. But signs and symptoms of hypoglycemia: anxiety, sweating, tremors, extreme hunger, rapid heartbeat, irritability, confusion, difficulty thinking, anger, weakness, blurred vision, slurred speech, staggering, poor coordination, seizures, and unresponsiveness. I think just simply looking at that list, you can say, I can see where the entire nervous system is being hammered due to the lack of sugar. And there's a couple of other things that get thrown in there. Extreme hunger. The body knows, I need the sugar, get me the sugar. And so that in and of itself is a wonderful piece of information to have. Yeah, he's just been starving lately. And it tells you, the body knows it needs sugar. So the most common cause of hypoglycemia is that excess insulin in relation to the amount of glucose in a diabetic patient. And then when glucose levels drop below normal, we see those fairly predictable signs and symptoms, which why we put this slide here instead of preceding, I don't know, but you can go back and say, the anxiety, sweating, the tremors, rapid heartbeat, irritability, confusion, anger, weakness, hunger, seizures, staggering, so on and so forth. So occasionally we also have some other problems that pop up where we have an acid-base problem. So we have an acid-base problem, an acidosis issue. Hypoxia leads to acidosis because carbon dioxide is an acid. We could get diabetic ketoacidosis. We talked about breaking down some of those fatty acids. The fatty acids create ketones as a byproduct. And those ketones and the fatty acids themselves create more acid in the body. Shifts the pH. It increases the amount of acids in the body. Toxicity from certain acidic substances, such as aspirin or salicylates. Aspirin is acetylsalicylic acid, and that in and of itself, you take a whole bottle of aspirin, you make your body very, very acidotic. Antifreeze solutions, amongst many other different substances we can run into that could potentially make us very, very acidic. When we get a metabolic acidosis, that means we have an arterial pH of less than 7.35 and a bicarbonate level of less than 24 millimeters of mercury. So what does that mean? When we talk about acid-base, we really are talking about a couple of key substances. Number one, are substances or measures. The pH. Obviously, the pH tells us whether we're acidic or we're alkalotic. So that's one of the first indicator. When we talk about the reason why we got acidic or we got alkalotic, that's where either metabolic or respiratory or a combination of the both comes into play. So a metabolic acidosis would mean that the body became acidic from a longer-term process in which the body has started to not be able to control its acids. We may have a respiratory acidosis. Respiratory acidosis is a shorter-term reason for the pH to change. Say the patient has been overdosed on opioids, in which their respiratory rate now dives down to, say, 6 per minute. And with that 6 per minute, that allows the CO2 to build up. And with that CO2 building up, what happens? But it builds extra acid in the system, and it creates that acidosis. We may have alkalosis. we were talking about an alkalosis, then that alkalosis is when the body's over expending, it's over processing and over ridding itself of the amount of acid it has. So maybe it's from hyperventilating, would be a respiratory alkalosis, or maybe it's from the kidneys are gone into overdrive and they're just dumping acid like crazy. Well, that could be a metabolic alkalosis. So we look at a couple of things. We look at pH, we look at the bicarbonate level, we look at the CO2, we look at the O2, and we look at another thing called base excess, which we're not going to touch on right now. So when we look at an arterial blood gas, and it's not something you're routinely going to look at, but it's worth at least mentioning. We look at that pH to determine acidotic versus alkalotic. And then if we have bicarbonate in a good range, then we tend to believe that it's probably more of a respiratory thing. We would take a look at the CO2s and the O2s and see where they're at, and that may help drive us to a metabolic cause. So it's a complicated thing. We're not going to spend much time on it now. We'll probably revisit that at a later point. So as pH decreases or they become more acidic, the hemoglobin becomes less effective at binding the oxygen. So the more acidic the body gets, the less likely that the hemoglobin is to work. So it's basically what we could say, if you thought about it this way, if you were hemoglobin and you were sitting in an environment doing your whatever it is you do for work, and unbeknownst to you, there was a carbon monoxide leak in your house or office or whatever, and slowly it's building up. Slowly you're becoming less and less aware, less and less alert, less and less functional, and that's kind of the same way that the pH and hemoglobin operate. It's going to force the cells to utilize anaerobic metabolism, and that's going to obviously produce less ATP. So when we have less oxygen bound to the hemoglobin, less oxygen makes it to the cells, and the cells have to do with less. Therefore, they go to anaerobic. We can also get alkalosis to occur when we have excessive amounts of bicarbonate or magnesium hydroxide as antacids are taken. So if you would, say, go home and eat a box of baking soda, or go home and take a bottle of Rolaids or Tums or Maalox or whatever, take the whole thing, you have now really neutralized a ton of the body's acidic store by neutralizing so much of your stomach acid, which really is a huge, huge, huge player in the grand scheme of pH for the body. So you neutralize that large bag of acid that sits in your gut, then the body's overall grand scheme really actually drives that pH up, making them very alkalotic. We may also have electrolyte abnormalities, and as we're talking about electrolyte abnormalities, we're talking mostly the things like sodiums, chlorides, magnesiums, potassiums. Those are the major ones. Of course, phosphates, we mentioned calcium. So there's a variety of those kind of base elements that our body requires for a constant, for its constant ability to do whatever it is it needs to do. We know sodium, potassium pump. So those electrolytes got to be maintained in that very narrow range for that cellular function and fluid balance. That's why when we use isotonic fluids like normal saline, we're very similar to what the body needs and deals with, and with that we are much safer to give a fluid like that than something that would be very high in electrolytes or very low in electrolytes and cause major shifts. Cardiac rhythms, electrical conduction, contraction can be affected. The ability to use even muscle contraction of your skeletal muscles is affected when the electrolytes are thrown out of balance. So when we're talking about somebody who maybe is hyperkalemia, when there's lots and lots of potassium in the body, potassium doesn't flow real quickly out of the cells, doesn't reset real quickly back into the cells for the sodium potassium pump. Things kind of get slowed down when we have too much potassium in the body. You might not have good reflexes. You might be very slow and sluggish to respond. So what happens to oxygenation when the pH is abnormally high or low? Well, pH is abnormally low, then the oxygenation is decreased because the body's unable to offload oxygen very quickly. It's not able to attach to and offload. When it's a higher pH, it may be able to attach and transport easier, but in most cases the body doesn't need it quite as much. As the hemoglobin saturation decreases, the overall oxygen availability to the tissues will also decrease. So this is going to force the cells to utilize anaerobic metabolism, and in hypoxia this further worsens the state of oxygen deprivation. In acidosis and in alkalosis, the reverse situation occurs. Oxygen is not as easily released at the cellular level. It's picked up well, but it's not let off easy. All right.